major questions which we'd like to go through with you. And we would really encourage this to be as open, and if you feel like being inflammatory, that would be great. If you've got some constructive comments, that would be great. But it'd be nice to reach at least some kind of consensus on what we can do to improve things. So, Mark, have you got the first slide there?
Yeah.
So I think a lot of you have been sent these questions to think about before joining, and I think these ones are probably less controversial than some of the others. But when we think about baseline characterization, should we have a minimum baseline beyond just the basics that are done in oncology trials, blood pressure, heart rate, and ECG? And what should we do if you think we should be doing more than that? Can these be standardized? Does anyone have any kickoff thoughts to that?
So this is Anupam Agarwal, and 2-3 years ago there was in-person 2 days cardio-oncology meeting, and in fact I presented on this very topic, that there should be a minimal not only baseline these parameters, but history also. We should standardize, because I have several examples from the past. Down the road, after post-marketing, when a cardiovascular safety signal emerges and you try to adjudicate, majority of the time you don't have enough information. I work in the industry now. I'm a cardiologist by training. In the past, I worked for Avendia, and I was personally involved in adjudicating, and believe it or not, in half of the cases where investigator reported myocardial infarction, there was not an EKG or cardiac enzyme. And how you will adjudicate an event of myocardial infarction without that? And the reason was these were diabetes trials, short-term, 3 to 6 months, and nobody cared if one event occurred in placebo, to in treatment arm. I mean, so I fully support collecting this minimal information.
Yeah, and I think, and Alice has made a comment in the text, is that, you know, who's going to pay for this? And part of the concern about this is not wanting to limit farmers' involvement and put them off. So we've got to be pragmatic. Anna, your hand was up.
Yes, can you hear me? I think that whenever you say, of course, like you could say, well, we just need an EKG and troponin. It would be very hard to argue against that. But I have to say that we have to think in the categories, like you just cannot say universe of oncology drugs. So even if you talk about novel drugs, even approved over the last 5 years, it's still a universe. So minimum sounds like a great idea always, but for some drugs, it's not going to make almost absolutely no difference if the patient doesn't have a change in EKG, or if they do go from normal sinus rhythm to sinus tach, it's nothing specific. So I see a value in getting an EKG and a baseline, at least troponin or a biomarker for most of the drugs with concern for cardiovascular toxicity. But if we want to make a major move forward, we have to identify what is the syndrome that we're going to be looking for, and how is the baseline assessment going to help you that when the patient has a symptom, or when you're concerned about the symptom in an asymptomatic patient, how are you going to know there has been a delta? So I have, whenever we talk about the definitions, I think we have to talk about categories of drugs.
And I think that's the theme that goes through all of this, which is, you know, do we have a blanket approach, or is this based on mechanism of action? And Tom, you may have some thoughts on that, or?
I was just going to address your first question. Should it be standard minimum? And I think that there's a real push now in the oncology world to accept, especially for immunotherapy trials, that there should be an extended standard minimum. If you look at the ASCO guidelines, which were just published in 2021, I think last week or the week before, they have now started to have this conversation about having baseline EKGs and considering baseline measurement of troponin. And that is a very new conversation, which is a bit of a paradigm shift, because those recommendations were not there in previous iterations of the immunotherapy stuff. And so for me, I think it's a bit of a, for me, I think I cannot see a reason why there would be a reluctance to add a baseline troponin to patients in clinical trials on immunotherapy. It is not that it will change whether they get the immunotherapy. It will not change, we'll do more testing if we find it. It's just when those patients who have many symptoms and the carers are trying to figure out, is this their cancer or is this something else that's a little uncommon? Having that baseline value just takes away a lot of the anxiety for the vast majority of patients who do not have any of these cardiovascular toxicities. And
I'm sorry,
yeah.
I want to respond to that. And I apologize to everybody who has their hands up. I can't figure out how to raise my hand as many Zooms as I've done. But, you have mentioned that, well, get a baseline troponin. And the problem is if it's abnormal. I have now worked up several patients who have abnormal troponin. It turns out to, with the help of the cardiologist. This is not minimum for us to recognize it's an abnormal test. It needs to be explained before I could put them on a trial. And it delays bringing the patient on study. And then sometimes after all that workup, I don't have a definitive answer as to how helpful that was. So it does require cardiologists to tell me, okay, that's just troponin, don't worry about it. Let's just get started. And I need a note from them, which means I need a cardiac consult. And it's not simply just get a lab test and deal with it.
If I may respond a little bit to that, Alice, I have the exact same anecdotes, which have far more serious outcomes, whereby we have had patients who've come in with non-specific symptoms with troponin, which are in the 20 to 100 range, which generally people with pre-existing cardiovascular disease, because it might be likely related to pre-existing cardiovascular disease, who've had to go in intensive workup, including MRI and endomyocardial biopsy. And we've had a patient who underwent an endomyocardial biopsy who had not a great biopsy, was negative, and so didn't have myocarditis. And so for me, the balance here is and we now have a protocol here whereby all of our patients clinically get a baseline troponin. And in an N of, it's approaching now 470 different, 470, because I'm keeping tabs of quick emails going, are you worried? The 470 out of 470 is, please proceed.
Yeah. Great points. But I think both points are valid. If you measure, we need to have a plan, help people, guide people what to do with them, and not let it treatment. But Tom, very, very important comment there. I want to make sure we get other people's comments here. And Elad, I think your hand is up.
Yeah, actually, so we do at the NCI have a trial that was recently presented at ASCO, EA6134. The presentation was not related to cardiovascular events, but it was a comparison essentially in BRAF mutant melanoma patients with nivolumab and ipilimumab versus dabrafenib and trametinib. What should be included? What should be given first? So at some point, Dr. Muslehi was actually asked by Mike Atkins, the PI of the trial, if we could add some screening troponin and EKGs to that trial. It's, I think, the only trial that we're doing that on. The data are not out yet. That was a decent sized trial. And in any screening evaluation, I think that one of the questions is, what's the number needed to treat, or what's the number, how large a number do you need in order to justify the intervention? And we have a lot of experience with that in cancer. As much as just one example, as much as we think that ovarian cancer, as just an example, is a terrible diagnosis, and we want patients to be tested and caught early when they have ovarian cancer, where they might be able to be treated. Ovarian cancer screening is not standard. Why is ovarian cancer screening not standard? Because it's not effective. And so, the question about this particular intervention, as whether or not troponin and EKGs are necessary as a baseline in oncology drug development, I don't think is actually answered. This is a specific cost, and it would affect some element of drug development from the perspective of the public sphere or the private sphere, increasing essentially a little bit of the regulatory burden if we decided to make it standard for unclear reasons. And so, that's at least where I would at least have some concerns in doing it in a way that is agnostic. Do we really catch more events on a mass scale by this method than we would by not doing it?
Great. Very, very important point. Maybe let's just move on to Ignacio, comment.
Hi, Ignacio Rodriguez from Novartis in clinical safety. I think that the problem that we have here is specifically with cardio-oncology and oncology per se, is that we have a high risk tolerance. This is not a problem in other indications where patients with significant cardiovascular risks are simply unacceptable. Here, if we're saving lives, we're going to tolerate much more. And to me, the critical thing is that the biomarkers that we decide to include at baseline and also later on is exactly what we're going to do about them. And some in this particular, to your question number one, which is the use of the biomarkers in clinical trials. We need to differentiate which of those biomarkers we need for the safety of the patients, and others that we need to better understand later on what happens on drug-induced effects. So if we're willing to tolerate a high risk from the beginning, it's okay that we take some of these measurements, but not for inclusion-exclusion criteria, but to better understand what happens later on. I think we need to differentiate if this is selection criteria or to understand what is being studied in clinical trials, which is ultimately what is the benefit and safety of the therapeutic approach.
I think that's a really good point, and I think that goes back to Herceptin, and it's about characterizing those patients who have the most to gain from a cancer point of view, so that the patients in the neoadjuvant curative setting actually have the minimized cardiovascular toxicities. Dan, you had your hand up?
Yes. So I put in the chat that there was a publication about a year or two ago in European Journal of Heart Failure about baseline risk assessment and different types of cancer treatments. And so it covered 7 different categories. So HER2 therapy, anthracycline, et cetera. And, it doesn't have the same, minimum risk stratification for each cancer treatment, since each cancer, class of cancer treatment has a different profile. So I think that, when you're thinking about what would be a minimum assessment, that is one place to start. I'm not saying that's the be all and end all of everything, but certainly it's a start. And then, in the case of checkpoint inhibitors, I think, we need to continuously reassess what we're doing. I think if you go back and look at the Herceptin story, you know, it wasn't, although from the cardiology world nearly 20 years ago, there was a call for taking Herceptin off the market because it had such a high rate of heart failure. It was more about, you know, finding a way to manage that problem. And then now over the next, you know, over the next 10 to 15, 20 years, with all the newer research and Herceptin and all the ways that it's given, you know, the rate of toxicity is quite low. And it's not zero, but it's quite low. And so it was all that research that changed the risk profile of Herceptin. And so I think that for drugs that do have important and highly significant cardiovascular toxicities, it's not about saying that, oh, the cardiovascular toxicity exists. It's more about what can we do to minimize it so that the patient gets the best therapy. So this isn't about just saying, oh, the drug has toxicity, therefore you take it off the market. It's about how do you manage that toxicity and minimize it. That's really the main question.
Great point. Well, we're going to move on to our next question, but Anna, you've had your hand up. Why don't you go ahead and comment, and then we'll move on to the next question.
Is that for me? I just put it in chat. I think that this is the key distinction. What Ella was saying is not to use troponin to screen for cardiovascular effects. I think we are in agreement with that. We are not screening. The problem becomes if we don't have a baseline and you have a patient who says, oh, I had chest pain this morning. They come in, they have troponin of 90, and just like Tom said, in order to prove that that's not myocarditis and they're not going to die suddenly, we are having to take the patient, if nothing is diagnostic, there's no gold standards here, so we take the patient to MRI. If you don't have an MRI, we send them for biopsy. These tests have risks to them. So, and the problem is, like, we do not know what are the troponin values in this population. So the proposal is not to screen. And Ignacio said the key word, this is not idea to get the troponin and EKG to tell that 50% of patients cannot come onto trial because they have a baseline of normal troponin. We do not know what the meaning of that is. However, since there are so far from all the trials, it seems that the abnormalities and the delta is the important. So increase in troponin, if that's a signal toward wrong, we have to be able to detect it. So having that baseline will allow us to actually diagnose clinically relevant event. The idea is not to screen for asymptomatic cardiovascular disease and exclude patient, delay treatment, change treatment, do anything with oncology treatment on the basis of that diagnosis.
Yeah, I think that's really important, and hopefully we do agree on that. I'm interested to hear what Sigrid thinks on this from an EMA perspective. I know you're not speaking on behalf of the EMA, and this is your personal opinion. With that disclaimer.
Yeah, I think, I mean, first of all, I'm not a cardiologist, so I don't have any input on what should be measured, but I was thinking actually more about question C. Should there be a standard set of assessments in all oncology trials? And somehow I feel that wouldn't it be great if we knew much more from the beginning, from the early, if a lot of this was done in phase 1 and 2, and then you could have a more risk-based application of these types of measurements later on. So I think it's really, I think as if more could be done in the early phase, and especially now that we tend to approve a lot of drugs actually on phase 1 and phase 2 data, I think it really should move to the earlier parts, and it should not rely on discovery through broad screening in the phase 3 setting, for example. this is just my personal reflection. But yeah, as early as possible.
What wonderful comment. Thank you so much. Ninian, what do you think? Should we go on to the next question just in the interest of
Yeah,
time?
I think in the interest of time, perhaps we should, yeah.
All right, go ahead, Ninian.
So yeah, so really what we're thinking about here is in follow-up, following ideally a nice characterization at baseline. And again, similar thoughts, but should the approach to event ascertainment be standardized? So what we mean there is, should we consider a phase 1, phase 2, phase 3 trial differently? Different drug classes, of course, mechanism of action. And do we change our approach in the context of the cancer stage and the competing risk between cancer, no option but to give the drug, versus the adjuvant setting? I think that's probably enough to get started thinking about. If anyone has any thoughts. Robert, is your hand up from before, or have you got some thoughts on this? You're muted.
As those of you who know me, I always have something to say. I think oncology clinical trials are very different than in other therapeutic areas. There is much less difference between a phase 1, if there really is such a thing as a phase 1 oncology trial, or really mostly phase 1/2, and a phase 3, except the size and the fact that you have dose escalation before you get to recommended phase 2 dose. Otherwise, there are patients, the vast majority, they're elderly patients who have cardiovascular disease, fall and break their hips, get influenza unrelated to their malignancy. So I think having a standardized approach, as I think most of us agree, troponin and ECG, we can argue about echo or assessment of LV function. I think that would be very wise. Even more important, as I think came up, Anu's comment at the beginning, we need to have a good set of history questions to know the clinical background, the history, cardiovascular history of the patients for every study, so that when the inevitable events occur, we can kind of put them in context without having that.
Basically, if I can summarize, then, sorry. So basically, if I can summarize, that basically means that you would be in a situation where you have an existing trial, but you're doing more PET scans, and the funding would for those additional PET scans would come from the NCI. So it's not a specific trial for to do PET scans on standard of care patients who are receiving Nivo/Ipi. It's a proposal essentially to pay for additional PET scans on existing trials.
I'm not sure that PET scans are
specific trials, yeah. Those specific trials, but it would be additional scans for those specific trials, right?
Sorry, who's commenting?
Eli, is that directed at us? Disappeared. Okay, so yeah, I think, and the other point that I've wondered about when putting these questions together as well is, should there be a different approach in patients with a limited life expectancy or trial duration? For example, I know we may accept that phase 1, phase 2 might not be so different in oncology trials.
So then
if you have
what I thought. Okay, so this would be a specific.
If you have a trial with a short follow-up, is that an opportunity to do enhanced cardiovascular characterization or follow-up? Whereas if you move into a phase 3 trial in a neoadjuvant setting, perhaps you've got the benefit of scale, and you don't need to do such detailed characterization, but you have the benefit of that scale, and you have a pragmatic follow-up, perhaps with electronic health records, where you have hard cardiovascular events rather than surrogate endpoints. Is that a reasonable proposition?
You have to break it down into data that you need to manage the patient, regardless of them being in a trial or not, if they have events, versus the data that you want to collect to assess the effect of the therapy and safety and efficacy. The management data are probably more similar for every study. The data that you would need to collect, if you're looking at program-wide effects, are probably going to differ by indication and by population.
Okay. So the other issue we come up, sorry, Amir, you have your hand up.
Yes, hi. My name is Tashwar. I'm a safety lead from Novartis. I'm not a cardiologist and I'm not an oncologist. I'm a pediatrician. For the long-term follow-up in oncology trials, I think it is important to identify things which are, the aspects which are going to be relevant in the going forward based on the population. That's one thing. And then the second thing is, for the previous questions that we had, I think it is important to address the baseline assessments based off of the mode of action of the drugs. This is probably applicable not just in oncology, but in other treatments for other indications where it is a life-threatening situation. The underlying indication is a life-threatening disease.
Great point. So tailored based on mechanism of drug and who the population is. I think those are good, very good comments. Now, I don't know, Ninian, we've got, I think, just a couple minutes. Do you want to try and get to the third question?
Yeah, I think that's a good idea.
Please keep the comments coming in the chat. These have been fantastic. All this is going to be recorded. Sorry, is this the?
So really, the final point we want to flag up is this opportunity with CTCAE in revision, and hopefully an opportunity through the ICOS definitions, which will be published soon. We really want to gauge enthusiasm for trying to incorporate those into the CTCAE, but also to understand whether there are challenges there and what modifications might be needed. Now, I appreciate that not everyone has seen these, but from a CTCAE point of view, and I'm glad to see Alice has got her hand up.
Yes.
Is this something you're interested in doing? You're muted.
Yep. So one of the things that just need to keep in mind is the CTCAE terms. I know that there were some comments about terms. It's not clear to me they were talking about the specific AE terms versus, I think one of the things you had mentioned was actually terms within the grading. We have a lot more freedom in terms of the grading. In terms of specific AE terms, they have to be meta terms. We, from version 3 to 4 went to extensive work to do that, and we don't want to go backward. However, within the grading, the one thing to keep in mind is you're working with oncologists who will be doing the reporting, so that if we change terms to a point where the cardiologist understands what it means, but the oncologist doesn't, then you do create some difficulty in terms of, the day-to-day grading. I don't want to, much as I love my cardiologist, I would hate to have to consult them on every cardiac adverse event to be able to interpret the grading. But, this is a great opportunity, I think, for us to work together to see if we can come up with terms where you're happy and I understand it. That's, I think, worthy. I have to be able to understand the grade.
So I think we're sort of running out of time, but actually, so Jörg, Herman, and Dan put the most effort into this document. I don't know, do either of you have any particular comment on this?
I'll let Jorg speak up if he's willing, but if he won't, then I'll say something.
Well, I can add to it, Dan. You're already on the goal.
No, I think that represents a lot of work for people all over the world that have expertise in cardio-oncology, and you know, we're actually very excited that we could come to a consensus and make some nice figures that summarized it. So I believe that you know, I'm very hopeful that this would be an important reference tool for investigators in cardio-oncology for sure.
Yeah, and if I may add, I mean, I think from what you've seen, from what Ninian has shared, we focused on just a few entities, whereas CTCAE is just like such a broad companion. And that I think is part of the challenge, that you have to cover all organ systems to every nitty-gritty detail. When it comes to cardiology, I think what we realized, or in a day-to-day practice, are the various other developments. In hypertension alone, if we take that example, we've had so many different definitions by different societies. And so to bring these together, but I do think it is very critical that we all talk the same language. And I think it's really the incentive behind that harmonized definition, I should say. We were not allowed to use the term universal, but at least to have that kind of consensus approach, because what the oncologist understands as being an issue might be completely different from what the cardiologist understands. And we heard earlier about bradycardia. We have, I mean, different perceptions of what really is concerning and what is not. And so I think it really is an effort to facilitate communication across the different disciplines, as well as aligning clinical practice and clinical trials.
Great comments. I think, as Ninian said, we're sort of going to get pulled back into the main session any moment now, but you know, maybe just to reflect for a second. I mean, we talked about baseline characterization. I think some really good discussion about what's used for inclusion in the trial versus to understand, you know, who the patients are and changes over time. Maybe Brian Rennie, you had a comment in the text about, you know, banking blood, so we can look later, and Tom Nealon, you had commented on that. So I think it was a very good discussion. We talked about event ascertainment and about how, you know, what phases of study, and maybe to tailor a bit based on the population. And then I think some very good discussion here, and there's been progress obviously for the ICOS and CDISC. And then Alice, you've mentioned in the chat here that you're going to share the CTCAE and get comments. I think that's very, very helpful. Before we get sucked back into the main session, any other comments folks want to add?
I have a super quick comment. Alice, this would be fantastic to see the new draft. And as you know, going back like 10 years now, I feel it's very difficult for an individual. If you send a draft to all of us, for example, the document that was mentioned, it was a group of people, like more than 25 cardiologists who do this, who try to understand at least the oncology world, try to speak the oncology language as well as the cardiology language. Could not agree on what should be the cutoff for grade 1, grade 2, because we don't have much data. So my fear is that, you know, keeping it at that level, like it was at the CTC version 1, you know, that individual cardiologists are providing input. I'm not sure that way you are going to get the most yield. Are there alternatives, ways of engaging with the CTCA providing input? For example, like this document is going to be coming out. How could we, as a group of very driven cardiologists, and we could engage the societies and others, provide input in a more, I should say, organized way?
So as you mentioned, Anna, and we're actually on version 5, but if there is like SITC, the Society for Immunotherapy had sent us, they went through every single CTCAE term, but which is not what I'm I think that y'all would want to do, but at least the cardiovascular terms, and please throw hypertension in. That is one of the most discussed terms that nobody's happy with. But if you could at least, at the start, maybe send us a list of the AEs of concern, then I'm happy to set up meetings to discuss, you know, but depends on which society should I interact with. If I interact with 6 societies, I will get probably at least 4 or 5 AEs that's going to have different opinions. But you know, we're from the CTCA standpoint, we love the experts' opinions, but the problem is we need to have experts agree within themselves that these are the changes that are important to be made. And I do understand as well that just like oncology, cardiology, things change with time. And that, you know, with each version, we probably need to have continued cardiology input to try to make sure with each version, we update both the grading, the definition, and add new events as it is important. So happy to interact. And you know, that's why I think this meeting is very important, but would love to be able to have more uniformity of agreement among the cardiologists, so that, you know, when we make the changes, I don't hear from another cardiology group that, oh, this is all wrong, you should have done it this way.
Well, I just like, as you mentioned, if you go with a CTSA, are they saying the same thing as ASCO? Probably not, but I think it's that level of comfort. So are you suggesting that this group could, I mean, there's a lot of us on the call, and we are just like oncologists, we are all on the CCAHA, you call it ICOS, so there's a lot of societies. And when we approach cardiology society, it's a different theme. They're going to say, well, this is such a small fraction. Most cardiologists don't care and do not understand what you're saying. So I do think it's a critical need that we try to move the conversation forward. So are you suggesting that this group could use the same approach? And if you could share how perhaps CITC approached it, so we could use the same approach with the current paper that's coming out.
So what CITC did was they actually set up a working group. And I actually made every single call of the working group where they went through every single category of CTCAE. And that's why I say I don't think it's important for y'all to go through every single category. We can certainly pull out ones that of interest. But they discussed every one and see if there was anything within that category. And they actually assign people to each category so that ahead of time they look through them and see if there are anything that they're worried about. And then they developed a whole list of either new terms, adverse events that they think needs to either the grading needs to be changed because management. So here's the other thing is that management of cardiac events has improved over time as well. So what potentially used to be grade 3 now can be easily managed and is no longer grade 3. We can easily manage those adverse events. Patients can continue on treatment without holding the drug. But so they did set up a working group that actually met almost every week to discuss these, to come up with list of AEs of concern. I don't know that that's, you know, but if there are people that are very interested, this is an area of great interest to me, because if we don't get the adverse event right, then we can't develop drug correctly. So I'm happy to provide the time to be in on these calls to help. Now I have to, one thing you said about ASCO guidelines do not, as far as I know, get into adverse event reporting.
They operate differently, and I'm by no means expert on ASCO guidelines, having sat on 2 of them as a cardiologist. So what I'm hearing is perhaps could be taken by Mark and Ninian as an action item, perhaps for this meeting, since we are all sitting together, as to say, well, maybe this is a platform that we can take it to the next step. And I think on a good news is that we would not need to be going back to square one. You know, Jörg and Dan share the sum agreement, so we could take what we've signed up so far as a platform to move forward.
Well, I think a great comment on it, and I think this would be a great forum, given so many stakeholders and different perspectives. So I think that's great. Not all of us were involved, I think, in the other statement, but I think certainly it would be a good way to collaborate. So Ninian, we can take that back to the group.
Absolutely. So we've got till the top of the hour. One final question is how best to disseminate information here. We've talked about publications, and obviously regulatory bodies are absolutely critical here, but beyond that, there's dissemination of the information and also training. There's a bit of a concern that there's such regional variation in terms of adverse event reporting, and it depends on whether this is an oncology nurse, cardiology nurse, any other. Is there an opportunity to do better in that regard as well? Does the NCI run anything in particular in terms of education around CTCAE or adjudication?
So when we came out with version 4, we actually ran a lot of boot camp training because version 4 was using metra terms, and it was a huge change. There is, I believe, Shanda is on and could probably provide more information regarding if there are training. We have a FAQ, frequently asked questions, for those people who are new to CTCAE regarding how to use it. The other is that the email, if there is somebody monitoring that email that from TRI, one of our contractors. And if you have any question about how to report an adverse event, they actually in real time reply to those questions. But Shanda, are you on?
I am. We don't have a formal training like you're discussing currently. We did, like Alice said, have a lot of trainings several years ago to train the trainer, really. So we trained our major cooperative groups for adverse event reporting using the new, that was version 4, CTCAE, and have largely left a lot of that training to them since that time. It is on my list of a million things to do as part of the update for 6, to do a more formal training from the NCI, also to have a much more robust frequently asked questions section, which I think will really help as well. We get the same questions over and over again. So yes and no, or no and yes.
So, just one quick question for Alice. I know a hypertension definition in last few years have become a mess, but for example, for myocardial infarction, universal definition, I think it is very well accepted. What is your view about recently heart failure universal definition came out? Did you see there is disagreement among even cardiologists and different agencies about that also? The universal definition of heart failure.
So CTCAE really is not to diagnose. So really the diagnosis of a heart failure would be I would work with a cardiologist to come up with a diagnosis and then look at the grading for it. And so that would be one thing that I think I had to teach SITC, was that really CTCAE is used to grade the severity of the event. It's not to diagnose the event. But if there's a new definition, then it is important for us to know that, to upgrade the so each CTCAE term does have a definition. It's not used for diagnostic purposes, but it is really used just to help define what that adverse event is.
Yeah, I think the universal definition of heart failure is obviously important, but it's not entirely suited here, because we're Obviously, the cardiotoxic effect is a slightly different thing. By the time you've got to heart failure, I think there may be more agreement than we've had so far with the harmonized definitions. I think it's probably a little bit easier by that point. The delta is the important thing here again, isn't it?
Well,
Okay, welcome back, everybody. If I could just ask the chair people of the 2 breakout sessions to just, if they could just take about 5 minutes each and talk about what was discussed, what were the issues, and what they think the future might hold, that would be great. Mark, Petrie, would you do us the honor of going first?
Yeah, sure. Thanks, John. So we had a very stimulating, very thought-provoking session. To be honest, I'm taken aback by how my personal opinion has changed over the course of the last 2 hours. I think cardiologists come to these meetings with a preconceived idea that what we do is the way that things should be done, but certainly not. And our conversation evolved to what I think might be a pretty good answer to adjudication strategies, and what we came to a reasonable consensus. I think maybe it was universal actually, that we might be able to establish a system where if you have a cancer hospital and you have a cancer trial happening and you have a cardiologist on site, that might be a very valid way of classifying events well. And most of us involved in cardiology trials are very aware that investigators who are knowledgeable are quite good at spotting what the cardiovascular condition is. If, on the other hand, you work in a cancer hospital and you don't have any cardiovascular clinicians, maybe then there should be some external availability of people who are able to classify cardiovascular events well. The exact mechanism of doing that, we didn't agree entirely. There were lots of other things we talked about. We talked about looking at or differentiating between late-stage cancers and early-stage cancers. And there's a feeling that maybe or possibly in late-stage cancers, cardiovascular event adjudication or capture may be less important. I'm not sure there was a universal agreement about that, but certainly in early-stage cancers, I think we did feel there was reasons for looking in detail at the cardiovascular risk, but not just in the short term, but short, medium, and long term. So those were 2 really, really fundamental, profound things we talked about. We did talk about other things such as baseline cardiovascular assessment and how that should be approached, and whether there should be standardized baseline cardiovascular assessment, whether that should be capture of cardiovascular conditions, cardiovascular risk factors. And we had a relatively long discussion about the use of biomarkers in cancer trials, so cardiovascular biomarkers like N-terminal-pro-BNP and troponin. I think that was the biggest disagreement. I think we've had some differences of opinion with regards to biomarkers. But I think most of us as cardiovascular clinicians are used to using these biomarkers and not overreacting to cardiovascular biomarkers being abnormal. And we touched briefly upon imaging as well, cardiovascular imaging. But of course, that would vary between the different trials. I think one of the overarching things which we keep coming back to is that we don't want to hold up the development of new cancer therapies. We want to really work together with oncologists and companies and hopefully regulators to come to some sensible agreement, which is not overly expensive, doesn't stop therapy unnecessarily. But I think most of us involved think we wouldn't stop therapy unnecessarily, we would carry on therapy. So I think we really have a feeling that there's a great deal of opportunity for collaboration between oncologists, cardiologists, industry, and hopefully if regulators get enthused by this and see the opportunities to clarify the event capture, that would be fantastic. So I think, even in the chat, we've been hearing from CTC people that I think there's probably is room for agreement. But Jim, obviously we've worked together a lot before. I'm sure I've missed a couple of large issues. So do you want to just to add anything to what my summary?
Yeah, absolutely. We had really an exceptionally good discussion, and what I would say very quickly, just as a disclaimer, as one of the card-carrying biomarker people, folks, I was actually one of the people who felt that biomarkers are overused, actually, because of the lack of understanding about how to interpret them. It creates more angst, and so establishing, clear guidelines with respect to when to measure, how to interpret is critically important, because I think we're trying to apply the standards for myocardial infarction and heart failure to a group of patients who have a very different physiology. In a global sense, one of the most important aspects that I think I took away from this, number one, is the general consensus. I think that people understand we're not trying to slow things down. We're just trying to be able to prepare for the natural life cycle of a drug that may make it to clinical use. So for a patient that's being treated with a non-curative intent, clearly the goal here is to prolong life as much as possible. However, in the modern era, more and more we're shifting towards a curative or semi-curative type of picture with longer term follow-up and indication drift after a drug has been available for a while, where patients treated with other types of malignancies for longer periods of time might occur. And so understanding and equipping clinicians with the knowledge of what to expect, I think, is critically important. And so that was, I think, a really clear message.
Great. Thanks, Jim and Mark. Mark and Ninian, for the other breakout session, I'm wondering if you'd share with us your thinking.
Yeah, I'll make a few comments and then I'll hand off to Ninian. We had a fantastic conversation, very engaged, a lot of common themes, and just in the interest of time, I won't overlap with all of them, but our three main areas were in terms of baseline characterization, event ascertainment, and then categorization. In terms of baseline characterization, a lot of overlap with what Jim and Mark Pitru said. There was interest in better characterization. I think there was interest in biomarkers, but the same reservations around, creating confusion at the time of inclusion. And if it's elevated, do you need to do a big workup? And will that then make it harder to recruit, or maybe even not make that trial available for patients? And some of the folks in the chat, came up with, I think, Brian Rennie and Anna Barak about, and Tom Nealon about just banking the blood. And so that it's not, the results aren't there to be an inclusion exclusion, they're just there to inform clinicians after the study of what were the baseline levels and what were the changes. So I think that was a good discussion, but I think there was a general consensus around getting more information would be helpful if we do it in a clear way. Resourcing, of course, had to be something that needs to be worked out. The second part for ascertainment was the same thing that Jim, you just raised. First of all, the comment was made, there's no such thing as a real phase one in a lot of these trials. I mean, they're in humans, patients are very sick, and you have to balance the ascertainment of events with how, the population, how long they're going to survive, and the mechanism of the drug. And so I think there was sort of a notion towards a tailored approach there. And then finally, for categorization, and I just want to really thank Dr. Chen for just really being very open about talking about CTCAE and engaging, and I think also helping to frame CTCAE as a grading, not as a diagnostic criteria, and to differentiate. While there are definitions, that diagnosis is different, and I think that's something the other group touched on. But I think there was a call for a collaborative effort to try to work with CTCAE on maybe terms and definitions and grading to come up with some consensus. Ninian, what did I leave out?
I don't think you left much out, Mark. I really enjoyed the conversation, and I think the common themes were that delta and good baseline characterization is good. and the most important thing, and irrespective of the stage of cancer, because those signals are perhaps not so relevant for patients with no option for their cancer treatment, but for patients in later phase trials and in the real world who are perhaps going to be cured, then these are really important things to understand and how to minimize the toxicity, as we were discussing at the beginning. There was a clear steer towards mechanistically targeted follow-up rather than a blanket approach. And really, I think the most positive thing is trying to move forward with CTCAE and ideally set up some better collaboration based on the ICOS document with the harmonized definitions, which will be out fairly soon. So no, I was encouraged. I think there were some pretty clear themes. There were one or two things that I think we can probably debate all evening, but no, I was very pleased, and I thank everyone for their participation.
Okay, thank you guys. Thank everybody very much. I know this is one of the few Zoom meetings that seemed too short for me, and the discussion got cut off. It's odd to say that, and I think that, I mean, we have, this is now over 2 hours into it, and we have over 75% retention rate, which is spectacular. We had 100% at 1 hour. So I think that shows the interest that is, and thanks so much. It showed the great work that the planning committee did. Thanks so much to our truly world-class faculty and support from the regulatory agencies, as well as our industry sponsors. We'll have some follow-up for everybody on this call, as those involved. We'll have an authorship policy coming out, and we'll be putting this into a manuscript. Additionally, if you have colleagues who wanted to see this but could not, it will be posted on the CTC website. I guess after, you know, they go through whatever scrubbing we have to go through to stop, in case anybody says anything bad. So thanks again to everybody. I wish you all the best for a very merry, happy holiday season and a happy and healthy 2022. So with that, we'll sign off. And again, much thanks to all for a rewarding afternoon.
Thank you.
Holidays.
Thank you so much.
Thanks, everyone. Bye-bye.